All right. Hi, everybody. My name is Justin Gardner. This is the November 2023 VTC Wilderness Medicine Journal Club session. This month, we're focusing on climbing injuries, also including some discussion of suspension trauma or suspension syndrome, and going through some cases and talking about other types of injuries and how to treat them. We're joined by our fellow, well, one of our fellows, TJ, and he's going to be going through this month's article. And then Chris Davis is one of the assistant directors of the Wake Forest Wilderness Medicine Fellowship. He's a BRAT instructor, a DIM instructor, former, uh, river guide,
Beard
man
aficionado.
of all trades, owner of an awesome dog. And he'll be going through after TJ's finished. I'm going to mute myself and TJ, take it away.
All right, I'm gonna share this screen here. You guys see what I'm seeing? Oh,
Yeah, looks good.
okay. Justin found this great article, kind of short and sweet, about suspension syndrome. Um, these are the authors. That is the title. And let us go. So, when they talk about suspension syndrome, also known as harness-induced pathology, it's when a person, either a recreational climber of some kind or some kind of professional, like a tree trimmer or some kind of uh, rope access person, is sitting in the harness for a prolonged amount of time, and there are documented cases of this leading to death sometimes. So they these the historically speaking, in 1972 was the first case series that was reported, and that consisted of 23 climbers, and 10 of those 23 died in that initial case series. Um, the leading theory on pathophys for suspension syndrome was thought to be the pooling of the blood behind the leg loops of your harness reduced venous return, which in turn reduced cardiac preload, which in turn reduced cardiac output. You became hypoperfused, you lost consciousness, and then you were arrested. That was the working theory, based on just kind of little evidence and more just assumptions. So here we go. The experiment went like this. There were 20 healthy adults. They did two tests per adult in a climbing gym off a rope. They hung them to an upper limit of 60 minutes. And then they would assess the venous pooling behind the leg loops with ultrasound. And they were looking at the superficial femoral vein, which, despite its name, is a deep vein. Um, the setup was they had each volunteer do two tests, two up to 60-minute tests, one without climbing and then one with 10 minutes of climbing prior to the experiment. There's some details about the ultrasound that they used, and they wanted to look at the diameter of the blood flow. They judged venous pooling by the diameter of that vessel, and they took baselines in supine positions and in standing positions before doing the test. Um, Kind of reiterating some of the same things, but they of note here, I think, is that they had echocardiograms done periodically during the evaluation to look at some details of the heart, and they had the patients on a monitor continuously, looking at heart rate, blood pressure, and stroke volume. The evaluations of the superficial femoral vein were taken about every 2.5 minutes, and it was done by two ultrasonographers. And their termination criteria was pretty well outlined. 60 minutes was the maximum. They would stop at 60. But if the heart rate exceeded 150 or was below 35, if the systolic blood pressure was above 200 or dropped below 90, if the GCS was below 13, or patients had symptoms of near syncope, they would end the test. So those are the termination criteria. Pretty reasonable, I think. uh, a very high altitude look at the results here. Um, they had near syncope incidence of about 30%, 12 out of the 40 trials. And for those 30%, the average suspension time until near syncope was about 44 minutes, which I think is a cool data point. Now, the superficial femoral vein diameter. So this is interesting. The they had a dramatic body change. Sorry, change in the diameter based on body position. Um, and what they found during the tests was the increase in diameter that you saw from just a person lying down to standing up was no greater in this test. So if you were sitting in a harness, your veins do not distend beyond what they would when you're standing. So they theorize that when you're standing, those veins are at um, their maximum distension, and they don't get any bigger, which kind of started putting into question the theories of the initial pathophys, I think. So, and then they also found that if you take them out of the harness, they quickly went back to their baseline. If they were supine, they would go back to that supine diameter. Um, so yeah, reiterating this again, no further increase during suspension phase when compared to the diameter of the vessel when the participants were standing. Um, and then they also found in their ultrasounds images and the videos that they took that the reduced venous flow would resolve partially if the subject was pumping their muscles. If they were moving their legs, you would see flow, you would see a reduction in diameter. But if they stopped that, it would quickly um, go back to its distended size. They also found in the patients, the people that had those symptoms of near syncope, there was no dramatic increase in the diameter in those patients. Um, and they also found that there was no significant preload reduction before near syncope. So the vital signs did not alter, the longer they were in the harness, and their cardiac output also did not change. It wasn't correlated with the time they spent in the harness. But those people that did have near syncope did have some heart rate and BP changes. Um, and I think that given all these details, they started kind of their theory kind of changed, and they started theorizing that the mechanism of these like near syncope or syncopal episodes were more neurocardiogenic as opposed to hemodynamic. So they believe that it was more of a neural trigger um, that might be responsible for the pathophys. Another thing that they talk about, and these are kind of, it's almost like they included this almost like as like a historical context, further context, because I don't think this was something that they um, really looked at in their study, but the cases of the rescue deaths were usually, or sometimes they were when a rescuer arrived at this patient that was stuck in a harness, released them from their predicament, and then laid them flat. And it was as they were laid flat that they would have these cardiovascular collapses. So one of the possible theories is they believe that maybe that sudden influx of blood that was pooled in the lower extremities causes a volume overload on the right side of the heart, causing arrhythmias and the hemodynamic changes necessary to or sufficient to cause some kind of cardiovascular event um, leading to death. So one of the recommendations they make, which I don't think is based on the research that they did, but they made it nonetheless, was that a patient should be put in a seated position as opposed to laying them flat initially to allow blood a gradual return to the heart and not just shotgunning the blood back to the right side of the heart and potentially causing an issue. So they also make some considerations about PE, but again, it wasn't something that they discussed in their research or that was considered in their research. Um, so they found that hemostasis could be a risk factor for pulmonary embolism, um, and that there is some literature that makes that connection of rope access and DVTs. But in the 1972 case series, which is one that they reference back to several times in the paper, they say that pulmonary embolism was not a factor in those, what was it, 23 cases or what? Limitations of this study mostly anchor on the fact that this was a simulation. It was done in a somewhat controlled environment and potentially not reminiscent of a real world situation. So if the subject was trying to be a good participant and didn't move their legs to get the best, data, that might be different than someone who's maybe stressed out in a harness and pumping their legs, or if these guys were hanging almost just like a foot off the ground. But in a real world situation, you might have like a small ledge or a texture on the rock that you're leaning against, standing on, which might also help activate muscles and limit venous pooling. Um, they and the leg movements could be varied amongst participants. So those are one of the big limitations of this study. So, like I said, short and sweet. Conclusions: venous pooling can lead to dangerous outcomes, um, but as opposed to hemodynamic implications, it seems to be more of a neurocardiogenic response that's responsible to that danger for that danger. Um, and then, secondly, movement is key. So if you find yourself in a situation, be mindful of moving your legs around, just like you might do, or like they tell you to do on a United Airlines flight. Squeeze those muscles and get that blood pumping to limit the negative effect of venous pooling. So now I will open the floor and any discussion, suggestions, questions. Let's get to talking.
Yeah, thanks, TJ. That was a really great summary of this article. I think that this really does bring up a lot of great points that we can discuss about study design, about the way that they did the the study, and then if we kind of systematically look at it, one of the questions I always like to ask is, number one, are like the results internally valid? Like, do their conclusions supported by their own evidence? And then like, what can we externally like do with this? Like, does this actually change the way we're going to do anything else? So those are kind of the two big questions I like to think about whenever I look at a journal article. And then I also like to kind of come away with what is my like a summary, like based on this paper, like what am I going to do with that? So kind of considering that stuff, yeah, I'd love to hear what you guys all think about this paper.
As far as internal validity goes, the conclusions that they make towards the end of the paper don't seem to be supported by the study design. I don't think I think it's reasonable. They're reasonable conclusions, but I think that what the study does do is kind of change our mindset on how we look at suspension syndrome, and I think it could definitely guide future research.
What do y'all think, the students on here? First of all, like really basic. So they said this was a convenience sample. Do you guys know what a convenience sample is? Someone know what that is? Is this like a randomized controlled trial? are these people that represent necessarily the patient population that we're that we're interested in? Like, what's a convenient sample?
I mean, in this case, healthy male volunteers who presumably liked hanging out around climbing anyway, which maybe is relevant for the group we're going to be studying, or that we want to know the answers for anyway. But
yeah, so like a convenient sample is basically like literally almost as it's described. It's like you just found some people that were nearby. Like, and if you're looking at it like big clinical trials and stuff, you usually do this for like a pilot study or something where you were like, we just like see if this is feasible or not. And like, we're not necessarily going to randomize people. We're not necessarily going to like, segregate people into a cohort that we're going to try to follow or anything. It's just, we found some people at the gym. They were nearby. This is what we did. And convenient samples historically are medical students. If you look at a lot of historical studies, convenient samples are usually made up of medical students because they're very convenient to roll a sample.
Hey, TJ, did you give a quick intro into what suspension syndrome was?
Yeah, suspension syndrome is it was a very brief sentence I made, but when a person is caught in a harness for a prolonged amount of time, leading to, in some cases, a cardiac arrest. The pathophys is not fully understood, but I think this paper does takes a step in that direction.
And
So I'm not trying to Oh, sorry, Chris, go ahead.
So historically there were like several leading like theories on how this has, and TJ sort of went through those. And one of them that he didn't mention that has been pretty well debunked by some other studies that were done. Some of my colleagues out of New Mexico did one looking at serum lactate levels and things as well. That was this idea that you had a harness on. It was like a tourniquet around your legs. And then when you let someone down off of it, it caused this massive release of cellular waste products and potassium and severe acidemia that would cause like sudden cardiac arrest because you just got like a massive sodium or massive potassium bolus to your heart and just like profound acidemia. So the rationale at that point was to treat people like they had a crush syndrome and to like load them up with tons of fluids and get bicarb and all the stuff before you let them down out of the harness. So that does not seem to be the case because, in some ways, if we look at the way that a harness works, anybody here ever hung in a climbing harness or anything before, even just like for a brief period of time? I know TJ has before. Does it circumferentially completely cut off blood flow to your legs?
No.
Nope, it doesn't. That would be horrible. Like no one would go climbing if that's what it did. So that just doesn't happen. And there's even been empirical data that's shown that you can't measure a change in serum concentrations of potassium or lactate or anything afterwards. So that's kind of debunked. So, but why? Could anyone explain to me like why that would be like bad for people to think that was the case and make their rescue strategies based off of that?
I mean, if they were treating it before they were taking them out of the harness, it keeps them in the harness longer.
Yeah, exactly. Like that's why these things sort of matter, because like if you're operating off of faulty pathophysiology, then you're potentially like not treat the problem. You're gonna leave them hanging in a harness for a long time when that seems to actually be the problem, is that they're hanging there. We don't know exactly why, but it seems like they just shouldn't hang there a long time. And so that's one thing from that. The other thing is that we know that when we hang in a seated harness position, we have, our large blood vessels, the femoral vessels, are not typically compressed whatsoever by a harness. Like you're hanging, those are in an area where they're not getting any pressure. So typically you're not having any like mechanical obstruction to venous return from your big vessels. You're not having mechanical obstruction to your perfusion distally from your like femoral artery. Like that's not obstructed. So like it was really illustrated well in there's a diagram. If anyone's like wants to take a deep dive, there was a review article published about 3 years ago by a gentleman named Roger Mortimer from University of California at Fresno, who kind of had a great diagram in it that sort of shows the way this works and kind of summarizes those things. But that seems to be not the case as well. And so this was a really good study that looked at one of the big thought processes, that it's like from significant venous pooling, but that really begs the question. I'd love to hear from anyone here whether you think this settles the score on that.
I mean, it didn't seem like it was helpful as far as the volume that was in the lower extremities, in the sense that you didn't see increased distension. Potentially interesting that it's commenting on stasis. So, I mean, you could have still decreased flow that's kind of transiting through the lower extremities, even if the volume that's sitting down there isn't increased. Although I was kind of, as I was reading that, I was actually thinking about the lactate potassium bit, because I hadn't read that other study you mentioned, and kind of wondering if that was a component, that there was enough stasis that you had some sort of lactic acidosis generating. But yeah, it's interesting that, yeah. So I think it didn't necessarily show exactly what they were trying to prove, but it also did show some degree of stasis. So.
Yeah, I think, and I think at some point in the paper they even mention, like, if there is a cardiovascular collapse after one of these kinds of suspension syndrome situations, to consider TPA if there's signs of right heart strain,
Right.
as a potential, last ditch effort to save the person. So, but again, not really addressed by their research, but definitely something interesting that needs further research.
Is anyone going to add TNK to their mountain rescue kit here at this point? They're going to put
just prophylactic.
Make that brain bleed just sing.
That would be excellent. See, there's some other great things in here to talk about too. So they suggest that perhaps the actual mechanism is like a neurocardiogenic syncope. How did they get to that conclusion? Did anyone?
I think they found that it was similar to like a vasovagal almost. That's almost like that same kind of mechanism. I actually don't know how they got to that. How they got there.
Did anyone else catch it? How they did? I didn't. So it's like sort of like just like a pet peeve I have when I'm reading a paper, when they suggest something as the thing, but it's not actually, like, nothing that they have really suggests that. That's fine to do, right? But we just have to recognize that, like, sometimes the best conclusions are we didn't find it, and that's fine, right? Like that's an okay conclusion to have in your paper. Let's just say, for example, that we were going to design a new study, that we wanted to look at that. Say that we wanted to design a new study based on what we found here, to kind of look at that a little bit further. Is there anybody got anything they'd be interested in doing? Let's design a few different studies here that we could sort of answer this question of, like, well, we know that the saphenous or the femoral vein diameter is not significantly increased. Like, how could you design another study that would test this theory that it's vasovagal or neurocardiogenic?
Can we measure vagal tone?
Whoa, I bet that's gonna be a Wooten Jones question right there. Can you measure vagal tone?
You can do it once.
Sounds like a more invasive study.
Well, if you would expect that someone was having a vasovagal episode, what would you expect to happen? I mean, this is a really good question for the medical students here too. What would you expect, like, vital sign wise, when that person lost consciousness?
Like hypotensive for sure.
Would they be really tachycardic? Would they? I'm sorry, I walked up on someone.
Oh, very bradycardic.
Yeah, they would be like hypotensive and bradycardic with that too. They would typically not be. Now, what if someone was suffering from a hypovolemia?
They'd be tacky.
They'd be tachycardic, right? So, like, some of this stuff is we can kind of look at just really some really basic physiology here. So you would kind of expect, if we were really seeing a true vasovagal episode here, that we would get this episode of like bradycardia and hypotension. What are there any other things that you might be able to look at with ultrasound that might that might be able to elucidate anything.
Well, and regarding that last thing you mentioned, did I miss it? Because they said that their like exclusion criteria or criteria for ending the study was Brady below, I think it was 35,
30.
Tacky
Yeah.
above 150. And I was trying to scan to see if there was a spot in here that said X number of people bumped out for this reason versus that reason.
They didn't. I don't think they reported that.
Yeah.
And included in the exclusion or the termination criteria was also signs of syncope, and that was like dizziness or
Increased GCS, yada yada.
yeah. It was like, so it's kind of vague or like subjective endpoints.
So
So I
that
think
makes it
that
kind of difficult if you exclude someone for suffering the thing that you're looking for,
Right.
right? Like, which is sort of like, but, and certainly I would like to have seen like how many people got excluded and why. Like, did everyone that got excluded was excluded because they had decreased GCS and they were all hypotensive and they were all bradycardic? Then that would like really support that their conclusion then that they were having a vasovagal episode, right?
Yeah.
What heart rate variability? That's, someone brought up heart rate variability. That's an excellent physiologic measure of their of basically sympathetic and parasympathetic tone, that and activity. That's something that in fact used to be a measure of heart health that we like before we had echocardiograms, things like that. They would look at heart rate variability like very carefully in a lot of physiological studies, and also use it for clinical monitoring stuff to look at heart rate variability. So
there was another study. It was more like just a review article on a suspension syndrome I didn't choose to include on this. And it does also mention that same suspected neurocardiogenic syncope as an underlying cause. But even they also just are throwing it out there as a potential hypothetical cause. And this study seems to just kind of branch off from that.
Yeah.
Their terminology is similar. And I'm sure they read the study. They just didn't seem to quote it. And then that's what you have to look for, stuff like what Chris was saying. You read a study when they're coming to conclusions that don't really seem to be supported or quoted from other studies, then it gets a little questionable.
Yeah.
And if they're going deeper into their secondary outcomes than their primary outcomes, and then their results are tagging along into not their primary hypothesis and their primary outcome measure, then you're starting to wonder really what's going on. And just look into that kind of stuff when you review articles.
Yeah.
it's more like they're just sharing ideas as opposed to coming to conclusions.
Yeah, and that's something just to be very, wary of with any literature that you're reading. It's like, just go back when you're done and look at their conclusions and see whether it even addresses their primary outcomes and stuff. And if it doesn't, like, they should be very upfront about that and be like, we didn't find these things and stuff, which is fine. Like, a lot of studies, you don't find what you're looking for. In fact, probably most.
And like I don't even call it an unsuccessful study, but like not proving your hypothesis like is not a bad thing.
Yeah.
There's actually like it's easier to obviously get a study published if it supports your hypothesis, if it proves something. There's a lot more studies that have not been accepted for journal publishing because they didn't prove their hypothesis. So they almost have like a little bias.
Yeah, I mean, it's like a negative results bias. Like it's something that's like very well represented. Like, so I mean, that's why we start with when you're designing a study, is you start with a null hypothesis, and that's kind of how you do the whole thing. I'm one thing I'd be very interested to see, may or may not be designing a study currently that look at this, is about using echocardiograms to look at left ventricular outflow of velocities and things like that. So because that could give us a little bit better sense of that, if you're looking at some different measures of my cardiac physiology and see what's actually going on with the heart. It's sort of technically a more difficult study. You have to have a very like a skilled sonographer that's able to perform echoes and get good views in someone that's suspended in a harness, which is difficult. But like you could like that, I think could add to it. And then also I think looking at other having a lot of other parameters like heart rate variability. I'm looking at what's the thumbs up thing?
Yeah, that was awesome. How'd you do that?
And also looking at looking at bradycardia. And I would now certainly, does anyone know why you think they had these exclusion criteria? Why they had to exclude people that were passing out and things like that? Particularly for our students.
You can get in trouble for hurting them.
That's right. Yeah.
All they got was pizza, I bet.
Yeah, so exactly, the IRB. So your institutional review board will kind of put some parameters on what you're ethically allowed to do in biomedical
Wait, even on med
research.
students?
Even on med students. In fact,
wow.
There's entire laws about this now, about how we can't just beat up med students in the lab anymore, because we
weird.
did it for generations. So we can't just beat up med students in the lab. It turns out that is frowned upon. So yeah, so that's very interesting. Anything else from any of the students on this article? Anybody have like a take home? Like, what are they going to do with this? Someone's hanging in a harness. What's your recommendation?
I mean, one thing that their study did show is that the diameter decreases with movement of the muscles. So I think staying active, contracting your muscles, is probably not a bad idea.
Yeah, well, like if the theory of pooling does, like, because I don't think we can conclusively say that it doesn't impact syncope, right, based on this. So, and we do know that it did decrease pooling to move your legs, right? So that's good. So like that, if the recommendation is move your legs to try to get the blood moving, well, we know that works, right? Even if you're hanging in a harness, like that's effective. So so that's good, right? So the recommendation to move your legs, that if that in fact helps, it does what it says it does, which is good. Anything else?
So as Chris mentioned earlier on, it was like erroneous beliefs in the pathophysiology of this can lead to improper treatment. So one thing that they were worried about was laying them flat or supine quickly, and that fear can lead to keeping them in the harness longer. So it was up until, honestly, like within the past couple decades that they would, I think it was in France, the study in France determined that they can actually lay them down flat safely, just like you do with most syncope. So it was leading to delayed extrication from the harness time. They didn't want to lay them flat. And there was recommendations like TJ was saying recently, with either having them move, or if they're to the point where they're obtunded or immobile or have some type of injury, you can put a secondary sling like under their knees and then use that to put them in a semi-sitting position. And that was a hopeful attempt to reduce pooling. So there have been thoughts on alternative means of treating them if it's like a delayed extrication or difficult movement to the ground. But understanding the pathophys, there is actual reasons for this. It's not just pedantic. So they thought that actually it can lead to like a sudden return from this pooled blood, not just the potential rhabdo, hyperkalemia, lactic acidosis, but they're actually thinking they were going to cause like sudden CHF, essentially like flash pulmonary edema almost. So it was kind of interesting, the change in thought since 1973.
Are any of y'all familiar with, I've seen different stuff at different points about like having a sling that you can rig up, that you can actually stand in the sling, which would, I mean, I guess it would partially get at what they were talking about of just moving your legs. There's obviously a higher degree of muscle contraction if you're kind of load bearing on those legs. Seems like there would be something of value there, but doesn't sound like there's much data to support it or deny whether that's worth doing. And mostly I'm thinking about in that setting, like a kind of a self-rescue, or at least an ability to kind of stabilize yourself while you were waiting for someone to bail you out, kind of thing.
That's a fantastic thought. And in fact, it was such a good thought that a number of years ago, OSHA required that fall arrest systems have some kind of deployable leg straps associated with them. So if you have like a fall arrest system, particularly they have like a dorsal attachment where you like end up hanging like face first, like people that work on roofs, people like they are now mandated in deer, like if you're sell like a deer stand, like a climbing stand, they have to have some kind of fall arrest system with them now too. I believe it's required. Also, those things now have these safety straps that like can deploy off the legs, and so that you can stand up and take your weight off them. Because in particular, these fall arrest systems, they kind of have a chest component. You hang face down and you're kind of helpless. Like you can't self-rescue. You have to like get to a rope that's behind you, and it's completely relies upon someone else to rescue you for those things. So that's where people could end up hanging a long time, because you're like hanging off a roof and you've got other guys on the job site, and like someone's gonna have to get a ladder or something because no one knows how to like do a rope rescue from.
We can't all be Chris Davis. Yeah.
Or TJ.
Not to mention, I would guess that those harnesses might not be quite as ergonomic, as far as maybe now you actually are cutting off like femoral flow, if it's an anterior strap or something like that.
Yeah, definitely. They're definitely not ergonomic. They're not designed for hanging in. They're basically designed to stop you from hitting the ground, you know?
Right.
So, and so they can be very, very uncomfortable.
Yeah.
So, and there was, in the New Mexico study, I guess if someone can find it and put it in the chat. It looked particularly at industrial harnesses too, and ones with like dorsal and ventral attachments and stuff as well. So it was an interesting study from that standpoint.
And just for comfort, like when we were practicing like vertical raising and lowering of a patient in a litter, like they're pretty much strapped in place. They can't move. Having it's called a Purcell Prusik. It's basically like an extendable loop, but with a Prusik that you can extend, for anybody who doesn't know. And then you can strap that to the patient's around the patient's foot, give them something to stand on. Granted, a little 6 or 8 mil cord, even with thick shoes, after a time does start hurting your foot. But you take that from the litter up until the other side of the litter, and you can make like a little. You can even do an X-Man where it's like extra support on the harness. But if you're just dangling there by straps in your harness, it's pretty miserable. And that's not even talking about suspension trauma yet, just comfort.
Yeah.
Any other questions on suspension? I like to call it suspension syndrome. They called it trauma for a long time because they couldn't imagine in 1973 that these people weren't injured leading to this. But I like to think of it as a syndrome. Any other thoughts on that before we move on?
If I didn't hate hanging belays already, now I have even better reason.
Yeah. It was actually, so TJ and I read a lot of articles on climbing injuries this month, and it's hard to find a actually like scientific article discussing some type of injury that maintains the fun and cool aspect of climbing. So like a lot of them are just some scientific little look at this minute little injury pattern. But hopefully this gives you a good like overview to why rescue in a speedy way is important. Thanks, TJ, for presenting the article this month.
Thank you guys.
Chris has some really cool videos and scenarios and pictures he is going to show. You ready to
story
take over?
time? And there's at least 2 people on this Zoom that will be featured in this presentation. At least 3.
Building a little suspense. Wow.
Maybe 4. There might be more.
God.
We'll have to see. So give me 1 second to pull this up here.
You ever take those snowshoes behind you out on the trail?
Oh, I was thinking about bringing them out this morning, but it was just a little warm. But let's see. Oops. And okay. Can people see this? Do the little thumbs up thing if you can see what's going on. Great. Very good. So we're going to talk a little bit about climbing injuries, and I'm going to try to go through all this in an entertaining way. There is no text in this entire presentation. It is entirely pictures. So that is like plays well to my my sense of attention and all. So just a little bit about myself. I'm Chris Davis. I'm at Wake Forest. I run our wilderness medicine program here. I have been doing mountain rescue and various forms of rescue and pre-hospital medicine since the early 2000s, where I actually worked in Durham with one of the other participants on this call in EMS there. And I've also worked as a guide in many different contexts on rivers, on the ocean, climbing as well, and continue to do most of that kind of in a professional realm now, still currently still guide and take people outside for a living, which is really, really fun. I also work very extensively in education, and that's kind of my biggest role now is in pre-hospital education, particularly through simulation. This was kind of a glimpse into my last week. I was doing some training for the state parks. This was on Tuesday. Was it today's Wednesday? Was that yesterday? Yeah, it was yesterday. Yeah. So, or it was 2 days ago. Working on trauma and trauma systems of care with our park rangers there in North Carolina State Parks. This unfortunate guy, Kelly, here fell out of a tree, and he's some of the TJ and Justin both have unfortunately had to take care of Kelly. He just keeps getting hurt over and over. And also do a lot of stuff on the water personally too. This was last week in Costa Rica. Took a group of people down there for some wilderness medicine training and fun on the Pequari River down there. I do a lot of work with our residents and medical students as well. This is a couple of our residents on a wilderness medicine elective this fall. We were on the Gauley River there in West Virginia with TJ too, and took our fellows out as well. I just had to put this picture in here, TJ, because I was like, man, this is so awesome. Picture.
Look at how deep like the raft is, so far below the water level there.
Going deep. So one of my favorite roles is working with our wilderness medicine fellows here at Wake Forest, and kind of collectively in our collaborative Southeastern wilderness medicine. Some would call it a mafia around here, where we do lots of joint training and education on rivers and cliffs and all over the place. So if you're interested at all in kind of pursuing any further like formal education in wilderness medicine beyond just sort of casually participating, certainly happy to reach out to me or Justin or TJ or any of the people that have done fellowships and things in it. There's tons of different ways to get involved. You don't have to do a fellowship in it, but it is a cool thing to do. And there are fellowships available even outside of traditionally in emergency medicine. There are a few different programs that offer fellowships for internal medicine as well as family medicine, and also for APPs as well. So you too could do all this fun stuff. And in fact, it is a living. So I also love working with our medical students here at the School of Medicine. Sienna, you're going to be in a couple of these here. But this is one of our medical students that's been involved in our certificate program. We have a 4-year longitudinal program in wilderness medicine that these journal clubs are a part of, participating as a part of. And as part of that, one of our medical students here, Sienna, did an elective at Glacier National Park. She is at the famous lodge where the Night of the Grizzlies took place there, where there was the famous grizzly bear mauling. Also, we do lots of local education stuff here. This is here doing a swiftwater rescue course at one of our local rivers right here near Winsdale. So, all right. So that's just a little background about like what I do and some ideas about wilderness medicine and what things you can do. And this is kind of going to look a little bit more at it from my professional life as a rescuer and as someone who takes care of people in the wilderness. And unfortunately, more frequently than I take care of people in the wilderness, I take care of people who have injuries in the wilderness, and then someone takes them to the trauma center. So like that's what I wish it could be the other way around more often, but realistically, for most of us, we are going to be seeing these injuries in the hospital more than we will be seeing them in the field. And so a big role, I think, of kind of way I see wilderness medicine too is a lot of public education and outreach, injury prevention, and helping people take care of themselves and make sure that our EMS systems are set up to be able to provide really high quality care. Because selfishly, I probably will eventually need it, and I want them to do a good job taking care of me. So So we're going to go to Linville Gorge. So who people in the chat or the thing, put your hand up if you've ever been to Linville Gorge before. It's a absolutely beautiful, wonderful place in Western North Carolina. It's the deepest gorge east of the Mississippi, and it is a very large wilderness area that provides lots and lots of opportunities for rescue. So I'm on one of our regional mountain rescue teams that responds to Linville Gorge, and I'm going to take you through a couple of cases that we've had recently over the past few years that kind of show a few common injuries that we see among climbers and people mountaineering. There are a couple of pictures of some pretty graphic injuries in here. So hopefully everybody here is in medicine and can handle some grossness. If you haven't, and you get ready for your clinical years, because you will see lots of it. So, all right. So case one, this is a case that I was peripherally involved with. So we get this dispatch comes across our text messages. We get text messaging dispatches from this area. And so Wolf Pit Road, Ruler's Head, caller states that he is at the top of Short Off Mountain and a friend has been struck by lightning. And I love the way they spelled lightning there, right? So it's lightning our load, right? So, this, I hear about this on the radio, listening to the call on the radio. The patient ends up getting, they make contact with them. The patient's awake, alert, and they kind of, as ambulatory, a hasty team gets to them. And a hasty team is typically just your first responding rescuers. They're usually the people that are nearby. They go into the woods prepared with some very basic stuff to, first of all, be able to survive on their own, for ideally 48 hours. You have food, water, shelter, and ways to stay dry, something warm, and some basic first aid stuff. I like to keep in that kit with me things to take care of march and pause. That's our first step in management. So march, our algorithm there is massive hemorrhage, airway management, respirations, circulation, and hyperthermia, hypothermia. Those are kind of our first things. And then pause is the next part of that is P, pain management, A, antibiotics, W, wound management, and then S, splinting. So if you can take care of march and pause kind of with your initial thing, you should be able to stabilize and provide like reasonable analgesia and stuff for most people, and at least stop people from getting worse if possible. So hasty teams can often be made up of people with or without a ton of medical training, with or without a lot of technical rescue training, but their job is to just go in, find the person, and kind of assess for needs, because often our biggest problem is that we don't have good communication, and we don't really know what's going on. You may be getting some really crappy text message out, maybe some broken up phone call, or it may be just third-hand information about what's going on. This patient, they help them hike out, and they offer transport to the local hospital, which is staffed by my group of emergency physicians that they somehow think is a crappy hospital. It's a 8-bed critical access hospital up there near Linville, and they're like, no, I'm driving back home to South Carolina, and I'm going to go to my hospital in Lexington, the place where I usually go. And so they clearly weren't that bad, right? Because they could drive home like several hours back to South Carolina. Well, we get a text message. So I think Wooten Jones, who's on this call, was on this text message thread too, about, hey, I just have a patient that checks in who has just said they were struck by lightning in Linville Gorge. And so it turns out, they were up here. Whoops. I was looking across. This is that mountain you see kind of on the left-hand side of this screen is Hawksbill Mountain. The one on the right is Table Rock. And then there's kind of a little bit further down is Short Off Mountain is the one where they were. So our friend texts us like, hey, I think that somebody from y'all's area just came down as checking in our emergency department. And sure enough, he checks in and sees this. So does anybody know what this is?
The Lichtenberg figure.
It is a Lichtenberg figure. Yes, this is a pathognomonic for a lightning strike. So it is a It is it is not a burn. It is basically a skin marking pattern that's sort of more consistent with like what you'd see in vasculitis than it is with like a burn. They last for a few days and they go away. They have this really interesting pattern that looks sort of like sort of fractals that scatter over someone's skin. So we ended up, even though I didn't go to this call, since I didn't get there because they didn't need any advanced medical things, I still kind of got to interact with this case because they happened to show up at another ER with somebody that worked with us there working, in another state after being struck right there in our backyard. So that was a very interesting case there from Linville Gorge. So that kind of brings up a few things about lightning safety. So what are some of the big risk factors you guys think about lightning? Like how do I not get struck by lightning? Like what time of day should I go to ridge lines? Like mid-afternoon in the summer, is that a good time to go up to above tree line?
Probably not. Normally you get thunderstorms afternoon.
Yeah, exactly. So like try to stay off ridge lines and things in the afternoon, and particularly in the summer, because that's a higher incidence of lightning strike. So planning ahead is good to be like up by noon and down by like 2 o'clock. What else? What are some other things? Like what if a thunderstorm is coming and you're in the woods? Do you want to stand, or you're in a big field? Do you want to stand around the biggest tree? Where's the safest place to be? Is it next to a big tree? Is it in the middle of a field? Is it in a evenly wooded area? So in general, we would want to try to spread out in like if there's an evenly wooded area where the trees are all about the same height, so that you don't want to be the highest thing around, and you don't want to be next to the highest thing around. So those sorts of things should stop you from should prevent being struck by lightning. Your best option is to be inside, but a lot of times in the wilderness we are not able to go inside. What about inside a vehicle? Is that safe? Yes. So vehicles are safe, and they're not safe because of the rubber tires. That's the other sort of misnomer. They're safe because there's like a Faraday cage. If you guys ever go to the Science Museum or anything and you see where you sit in that metal cage and like the lightning bolt goes all around the outside, or when you remember from physics how the charge distributes all around the outside of something, well, that's why it's safe, because you're in a big metal cage and the charge will distribute itself along the outside of it and not go through it. It takes the path of least resistance. So you don't want to be the path of least resistance. All right. So case number 2, again, takes place in Linville Gorge. It's in a place called the Amphitheater. So this is looking down into Linville Gorge. The area you can see kind of up at the top left, that mountain right there is Short Off Mountain. That's where the last case took place, was up there on the top of Short Off Mountain. So you can see it's kind of the last big peak before it opens up into to Lake James, which is a big lake that kind of heads off into the Piedmont there. So it's very exposed, very high risk for lightning. But this one takes place down the gully here that you can see directly ahead of us. There's this big chimney. You can see right in the middle of your thing. That is the typical descent down into the amphitheater. So since this is a gorge, rock climbing in the gorge, you have to start at the top and then you have to go down into the gorge to start climbing, and you climb your way back up. So in many ways, this is very committing. If you have problems when you're at the beginning of your climb, you can't just take people out the bottom. You've got to take them back up to the top. So in many ways, this presents your most challenging environment for mountain rescue, because on many, the majority of places that you climb, the mountain rises up out of the valley, and you drive in from the bottom, and then you hike in from the bottom. And so when people fall, they usually end up at the bottom, or you can lower them and use gravity in your favor to get people back to the bottom, and then you can hike down the hill and back to where your vehicle is. When you're in a gorge, unfortunately, you have to raise people and out of the gorge, because if you were to go down from here, you would be following a really bad, rugged off trail. There's no trail that goes down that side of the river, for miles and miles and miles and miles before you get to a road. So there's no good way out that way. It would take, carrying someone would probably take more than a day to get them out that way. So you have to raise them up. And it's the amphitheater here has a couple of routes on it that are really classic and are pretty easy on the Yosemite decimal scale, which is how we rate rock climbing routes. They are 5.5, 5.6, 5.7. So kind of on the moderate to easier side of things. So it's a really popular place for newer climbers to go. Unfortunately, it's also very remote. It's about a 2-hour hike from the parking lot to get down to it, and it requires technical scrambling and route finding to get to the climb. So as you can imagine, if you're a brand new climber, you're coming right from a gym or something, climbing inside, this is not actually a very easy place to climb. And you think, well, it's only 5.6. So people may think, oh, well, they look in the guidebook, say, oh, it's 5.6. That's a great first climb to do. But when in reality, it's 5.6 and it's in a wilderness area and it's really hard to get to. So, so that kind of plays all into what happened here in this case. So, the way to approach this area here, you're going to drive up to the Chimney Rock parking lot, which is the Table Rock parking lot, which is that really cool flat top mountain we saw at the beginning here. And then you'll hike a few miles down a trail, and then you'll drop very steeply down into that amphitheater, which is where it's represented by that pin at the bottom of the screen there. So we got dispatched to a call. It was a Saturday afternoon, probably about 2 p.m. I am at home. We got a dispatch for a SAR and it was climber fall, broken ankle at the bottom of the climb is called the Mummy. So, we knew based on that route as climbers there that this was going to be a very difficult place to get someone. And so at that point, I'm about an hour and a half from the trailhead there, maybe almost 2 hours from the trailhead. I don't typically respond right away to most of these rescues unless they sound like it's very legit, because most of the calls you get turned around before you even get there because it's someone that was out of water or something like that. They don't need technical rescue skills, they don't need advanced medical care and stuff, but this one sounded like it was going to be pretty legit from what we were getting. So we have the benefit of having a radio network in North Carolina that is kind of statewide. So I was able to pretty quickly get in contact with command and stuff there. And probably after about an hour and a half, I was almost there. They had gotten it. Well, I was maybe about 2 hours in. I was getting pretty close. They had made further contact with the parties there and confirmed that they had a broken ankle, was what we could tell. They were at the bottom of the Mummy, so at the bottom of the amphitheater. And we had a hasty team that was assembling, getting ready to go in. So we had 2 rescuers getting ready to go in, or actually maybe it was 4. It was the base of this route here called the Mummy. Down here at the bottom, you could see we heard that as I'm getting there, we have had the first hasty team going in. One of the team members started having back pain and had to stop making any progress, which kind of slowed things down. And then probably right about the time I was getting to the parking lot, they had made patient contact. One of our paramedics had made patient contact and confirmed the patient had an open ankle fracture. So I rallied with another one of our rescuers, and I kind of put together a kit of stuff I thought we might need, because at this point we had 2 people with the patient, and that was all we had. And we knew that if we were going to take care of this person, we were either probably have to spend the whole night, because at this point it's about 4 o'clock. It's in October. And I'll kind of take you through the weather conditions a little bit more. I was thinking we might be bivvying overnight with this person. If not, we're going to be doing a technical raise, and our best chance would be if we could fly a mission from our helicopter hoist team that we have here in North Carolina called NC Heart, which uses a Black Hawk helicopter, National Guard helicopter, to be able to hoist patients out. But as you'll see, there were some reasons why I thought that may not work. I also, from what I could tell, I've been communicating the radio with the paramedic down there. It was an open fracture. And it was significantly displaced. So I also brought some lidocaine, because I thought we might need to do some regional anesthesia, and I may need to attempt a reduction if we're going to be there all night. And I was also brought additional doses of antibiotics, because we may have to redose the ANSEF because he had gotten 2 grams of Ancef. But if we were going to be there all night, we were going to need more antibiotics. Because at this point, we only had 4 rescuers that were going into this patient. And it was getting late in the day. So, first of all, I'd want to give you guys a little background on how this accident happened. So to give you some background on rock climbing. So there's kind of 2 ways that we typically climb with ropes. One is either leading and the other one is either following or top roping. And one of those is what this guy is doing here is you see he's climbing up the route and he has the rope attached to him and then he's clipping into protection as he goes. So someone is belaying him. So they have the other end of the rope and they are letting slack out. So as he goes, the rope gets longer and he attaches to different pieces. So if he falls, he will fall the distance he is above that piece times 2, right? Plus however much the rope stretches to slow him down. So if you can imagine, when you're not that far off the ground, you don't have a whole lot of security because you could easily fall and hit the ground. You could fall and hit the ground before you put in your first piece of gear, right? So because you don't have any way to stay off the ground. Or if you put in a piece of gear, then you climb too high above it before you put in your next piece of gear. If you fall, you can hit the ground. This is in contrast to this would be top roping, where the rope goes from your belayer there at the bottom all the way up to the top and then down to the person that's climbing. So as that person climbs, they take up slack and the rope gets shorter and the person doesn't fall very far at all when they fall. This is also what would happen if the first leader goes up the route and they either put in gear or clip to bolts as they go, and then they bring the other person up to them where the rope gets shorter as they climb. So that's kind of the 2 things. This person was leading. He was a new climber. He had been climbing for about 2 years in the climbing gym in a city. And this was one of his first outdoor climbs and one of his first outdoor leads. And he climbed about 10 or 15 feet, about 10 feet up, was trying to put in a piece of gear. He put in a piece of gear, and while he was trying to clip the rope to it, he fell. So he fell about 10 feet, landing on his foot. So this is the hike in. So at this point, we've got some information. We're hiking in with me and one of my buddies from the team. It was kind of a cool day. This is what our weather conditions looked like. It was sort of cloudy and hazy. It was probably about 55 degrees, and it was pretty windy. Someone had set up a high line across this area called the Chimneys here. For anyone that's into high lining, slack lining, it was kind of cool. And that second line there was flapping really hard in the wind. This is video now. So by the time we get to the top of the descent gully, this is where we're looking, the way we're going to have to take the patient out. It's probably about 800 feet of this to go down in there through this kind of terrain, very steep, very muddy, and lots of loose rock going through there. This is also what the weather conditions were like. So you can see it was pretty windy. And thinking about needing to use a helicopter hoist, this is concerning because wind and trees are not your friend when you're trying to hoist someone with a helicopter. So as we arrived, we're setting up some anchors here to try to descend at kind of a steep exposed slab here to get down to where the patient is. This is my buddy Will Soper, who is there with me here. He's building an anchor. We arrived to see the patient, and this is the injury that we see. So this is obviously not there. There's an x-ray board under there. I didn't bring my x-ray out there with her, but this is the patient has a severe open fracture to his right ankle. So what are some of the considerations that, particularly for our students, that when you see this injury and you're down there in the bottom of this gully, what are you thinking about?
Blood flow to the foot. Your tibial neurovascular bundle runs right down the medial side of your ankle.
Yeah, so like that's the first thing you're thinking about does he have neurovascular compromise, right? So he on exam had perfused toes. He had palpable pulses. He was able to move all his toes. He could feel them. There was a little bit of a paresthesia. It was not too bad. What else are you guys thinking about?
Contamination.
Contamination's a huge one, right? So this guy's in the woods, in the dirt, with bones sticking out. It's going to be that way for a long time, right? So you're going to want to wash that. So we kind of washed it off really well. I made the decision that since he had intact neurovascular exam, and it was contaminated, and we were able to give him some antibiotics, and we weren't going to be able to really decontaminate it that well, I was not going to reduce this unless we couldn't get him out of there, and let them do that at the hospital. So,
hey, Chris, mind if I mention something real quick?
Yeah.
That just brings up a good point. I see it all the time with the students and residents in the ER, is there might be something cool, something gross, something fascinating as an injury. Always remember to check ABCs first or go through March first.
Oh yeah.
Pulses are part of that, but just because there's this cool, gross wound, make sure they're breathing, they have a good heart rate, they're perfusing well. Don't just focus on the injury. Obviously, that's why the patient needs rescue. But get to that once you do a quick preliminary survey.
So that's a really good point. Like, so this guy, it was a pretty bad mechanism, but in the grand scheme of things, it wasn't actually a terrible mechanism for like multi-system trauma. He landed on his foot. It pretty much broke his ankle, and he was pretty okay otherwise. Like, we thankfully, at this point, we realized with this injury, this guy's not walking out, right? The true ABCs of wilderness medicine is ambulate before carry. But he was not ambulating. There was no way this guy was going to ambulate out of here. And we had 4 rescuers there with the patient. Does anyone know how easily we could have with 4 people evacuated this person out about 800 feet of steep slope in the dark and then 2 miles of trail?
Impossible.
No, there's no way, right? And we had a few extra resources coming and staging, but like we did not have a lot of people there at this time. There were only 4 of us down there. It was very difficult to access. It required some local knowledge and a lot of technical skills to be able to get there. And so we just did not have a lot of people there. And so thankfully, NC Hart, our Black Hawk helicopter, was able to fly. And that is not rotor wash. That is how windy it was with us right now. So they are hovering out in the middle of the gorge, and we're talking on the radio, trying to come up with a plan on how they're going to first of all find us, because we're at the base of a big cliff and we're in the trees, and then how we are going to get them hoisted out. So we went up and set up a big flagging tape. We went to a big bluff and we set up a bunch of flagging tape to sort of serve as a windsock for them and make it easier to see them. And then we flashed them with our strobe, and they were able to find us and get us there. I think this is a great time to talk a little bit about helicopter hoist operations and how that all can work in mountain rescue. So this is from a training we did with the Virginia State Police, which has a sort of similar program. They have a hoist program in Virginia. And with the WMS elective last year, they did some helicopter hoist demos for us. So there's kind of 2 different ways that you can rescue people with a helicopter. One is to hoist them, and that is using a dynamic line that will either raise and lower someone out of the helicopter while it either hovers or flies. Okay, so this person is being hoisted. They're being lowered down to the ground out of the helicopter. Okay, they will then, typically most of the teams that I've worked with will then take whatever litter you have and then put this thing called a Bauman bag around it. And it's this big Cordura bag that will cover your entire litter, and then hook it up. And then either attended or unattended, start hoisting the person back up. So they will get the hook. It has a big hook on it. They will hook up the person. If the person does not need to be immobilized in a litter, sometimes they can put them in something called a screamer suit, which is just a giant bag that you put the person in, and then they will hoist the person up like this. This is one of the issues, that if you are having to hover in one place, so this is a screamer suit that they have there on that person, is the rotor wash creates helical airflow and like creates a vortex and will tend to want to spin things. So you'll see they have what we call a tag line, or another line that's running off of his back that's trying to keep him from spinning. You have to attach a little weak link, something that breaks away at like 25 pounds in there. A lot of times you'll use like a little crappy keychain, Fastex buckle or something. And then when they get close, the person on the ground pulls really hard and breaks it loose. The other thing you can do is obviously they can't fly forward right now because he'd run into trees. But if you start forward flight, that displaces the rotor wash behind the helicopter and then will stop spinning. So a lot of times what they'll do is they'll clear ground obstacles, then break the hoist line loose, break the tag line loose, and then start flying forward. It's much easier to control litters when there's forward flight. So this is an example of them hoisting a litter. They're using hand signals to communicate with the pilot, and they're going to use a tagline here as well. So this is a very difficult operation for the pilot to maintain a hover while they're doing this, because they have a changing center of gravity and stuff. It's very, very difficult and very, very dangerous to hoist. So another option other than hoisting is called short hauling. It's able to be done in different sorts of terrain. Short hauling is done as demonstrated here by the Rangers at Zion National Park, who have a teletac program, is a static line fixed to the bottom of a helicopter. And it will pick the load up off the ground, and it is not brought on board the helicopter. So you will then be transported dangling below the helicopter, and then put down somewhere. So here they are flying through Zion, and they will are able to insert people into really difficult to access places. Short hauling is very difficult to use in our terrain here in the southeastern U.S. Can anyone imagine why this would be very hard to use? What looks different about this than where we were?
Trees.
Trees. Yeah, we don't have, that would be really hard to do with lots of trees. So they were able to thankfully get someone on the ground to us, and we had to go up the hill. We were able to package him in the litter. He's got pain meds on board. He's doing pretty well, and we're getting ready to hoist him out of here. Unfortunately, it's starting to get dark, but you can see him there in the Bauman bag, and we've got our NC Hart folks on the ground with us here, and thankfully, right about the time it's getting dark, we get the patient loaded in the litter, and after multiple attempts of trying to drop the hook from the hoist down and getting stuck in the trees, after dark, we have this patient hoisted off sketchily through the trees. Thankfully, these Blackhawks are able to hover for a really long time, and that was what kind of saved us here. They can fly for hours with the amount of fuel they can have on board, which is kind of beyond what we're able to do with most civilian aircraft. It's very nice to have that program available for us here in North Carolina. So there he is off to safety. This is what his x-rays looked like when he got to the hospital. And he made a complete recovery and was climbing again about a year later. So good outcome. And it can kind of show how complex medical care can be in a bottom of a gorge. So next couple of cases take place a little bit closer to home. This is Pilot Mountain. This is right around the corner from us where we live. And those of you who come take any of our rescue courses for it, this is kind of our classroom, and this is our backyard. So case 3, it takes place on a route here at Pilot Mountain. It's a very popular sport climbing area, and it is it can be very popular on the weekends. It has a lot of short routes, very featured rock like this. This is our fellow from last year, Alex Danello. I'm doing one of her first ever leads there. And this is a group of our awesome medical students here on a trip out climbing at Pilot Mountain. right around the area where this next accident occurred. So this accident occurred at the top of a route called Chicken Bone in the parking lot area. This is us doing some rescue training at the top of that route a few years ago. I think this was the year after Justin was there, but this is a beautiful fall day, not unlike the day this accident occurred. That's Carver, who some people may know there. And so the patient was climbing this route and was about where that climber is there on this route. That's the same route there, Chicken Bone. And they had a lead fall. So what happens when you have a lead fall? Well, this is what happens when you have a lead fall. So this person has climbed above their last piece of gear. They fall. And then particularly if you jump out away from the rock, it creates a big pendulum where you can kind of very forcefully slam your ankles into the wall. And you can see it very here. And now you would think that the farther you fall, the worst. But sometimes actually very short falls can cause a very violent pendulum into the wall. And she had we call a hard catch, or really kind of a bad belay. Her belayer was a lot bigger than her and took out slack as she was falling. So she actually had a very violent stop and then pendulumed like that guy did very hard into the wall and suffered an injury to her ankle. I was working in the emergency department that day and got some text from the Rangers. I was like, hey, we've got a bad ankle injury out here. And she's coming to see you. And that's what her ankle looked like. Again, what are we worried about here? Contamination, neurovascular compromise. She did have neurovascular compromise here. What would anyone recommend immobilizing an ankle in this position? No. So we typically tell people and lay people and even EMS that like to don't try to reduce fractures. But in reality, if you are in any kind of wilderness context, you should not try to immobilize something that is this badly displaced. Like you should try to straighten it back out some, because there's just no way you're going to get good neurovascular flow beyond this injury. So she was splinted. Thankfully, this is not a deep gorge. This is probably about only a 30 or 45 minute carry out from where she was, and then only a 30-minute transport to the trauma center. So she arrived to the trauma bay not too long after it. We were able to reduce it, clean it, had a great outcome, got an external fixator, did fine with that. So but you can see is a very common, when it comes to bad injuries in climbing, that ankle fracture is a common bad injury that I've seen quite a few of. The next injury is another one that I took care of in the emergency department. I unfortunately don't have pictures of this actual injury, but was a very interesting one nonetheless. This took place on a route called Black and Blue Velvet in the amphitheater area of Pilot Mountain, which is different from the amphitheater area of Linville Gorge. Very, very different. The amphitheater area of Pilot Mountain is like 15-minute walk from the car and like really accessible and all bolts and like pretty cool, versus Linville Gorge, which is like a nightmare to get to. So this route is rated 513C. So it is a much harder route compared to the Mummy 5.5 or 5.6 that the patient was on from that first case in the amphitheater. So this person was climbing and was trying to make a move and missed and tried to grab the quick draw when they were following there. So the quick draw is that thing you see hanging off of that the wall there right above that guy's head. This is again on Black and Blue Velvet. And it was at this bolt here. He tried to grab onto it kind of as he fell. He was a little bit higher, and sort of what happened? Well, he grabbed it, and then the carabiner became embedded in his hand. And it looked somewhat like this here that we see. So it caused a lot of damage to his hands, to a lot of the, it disrupted a bunch of his tendons. He had to have a ton of reconstructive surgery and stuff to his hand. But kind of is one of the other big things that we teach is don't grab any carabiners when you're following. try to, if anything, grab the rope right in front of you, right where it's your harness, or keep your hands out in front of you, but don't grab onto carabiners when you're falling, because that can happen. It's the only time I've ever actually seen that happen. There are some other case reports of it, but it is ultimately horrible, horrible luck, because you could do it 100 times and that wouldn't happen. He was just very unfortunate. Interestingly, one of the other people climbing there was one of our hand surgery fellows when this happened. But as you can imagine, probably nothing that hand surgery fellow could have done there at Pilot Mountain that could do anything to help this person. So that is a splint, decontaminate, and transport to the hospital. And there's not really much we're going to do in the ED either, other than try to get that person to a hand surgeon for repair. So that just takes you guys through a few interesting cases that we have had around here over the past few years, injuries related to climbing, and some of the challenges that we have when taking care of them in the field, and then also some of the management that we have when we take care of these people here in the emergency department afterwards. So any questions from anyone here about any of that stuff?
Yeah, I had a question.
Yeah.
So what is the pain med of choice for, say, that the helicopter rescue? Is that based off of what you have on hand, or under the precedent that he's not entrapped, or how did you decide that?
That's an awesome question. So like when we're considering like pain management in the field, like when I was thinking about that with this guy, I kind of have like tiers of what I like to do. And so ultimately I like to utilize multimodal pain management there. There's not going to be one magic bullet that's going to do everything. So we want to try to get it from every standpoint. So we want to start with stuff that's simple, right? So pain management is like splinting and immobilization goes a long way to managing pain from fractures. So you want to make sure you're getting everything you can out of that. We know that we've got multiple different pathways from which we experience pain. So also you're going to want to give things like NSAIDs and Tylenol too. Those will help as well. And then typically with severe pain, we're going to want to use some sort of opioid as well as an adjunct. But that with the other things is substantially better than any just one thing. So I would want, simple things like splinting, Tylenol, ketorolac or ibuprofen. And then we typically, in the sort of trauma patient, the pre-hospital environment, we use fentanyl, which is very predictable. It has, it's easily titratable. It has a short duration of action and a short time to its peak effect. However, if I'm going to be taking care of someone for a long time, that is also not beneficial because you have to redose it frequently, and you then will have to have lots of it and to be frequently redosing. So typically I would try to get initial control over someone's pain if I have options with something like fentanyl to try to get the pain under control. And then once I determine that they have some durable stability of their hemodynamics, like they're not going to crash, and they've kind of demonstrated that over an hour or so, then I would move on to something that's like a little bit more long acting, like morphine, or in our case, we had hydromorphone that we used for him. I got, I think, a total of 3 milligrams of hydromorphone over the course of 3 hours with this. So, which is a fairly sizable dose, but not that much for someone who's pretty, you also have to take into account, particularly people that might be a little bit hypothermic, are going to have delayed metabolism of some of these medications. So you have to consider like spacing your dosing intervals out a little bit longer for some of those, particularly your longer acting opioids, because the metabolites will build up and they won't clear them as quickly, and people can become overly sedated with them as well. So if people are shocky and a little hypothermic, you just want to space out your dosing a little bit more. That's a great question. I had one person on the chat asked if the blade was anchored to the ground, would it have been less severe? In fact, this is a case with those things when the blade is anchored to the ground, it'd usually be more severe. Let me see. I'm going to actually share this video again. It's a really interesting concept here. Let me share again and kind of explain why that happens. So we can see here, as this guy is getting ready to fall, his belayer goes up in the air, right? You see how that belayer goes up in the air? And as he is coming up, the guy up there is slowing down slower, right? So the thing, like with any fall, is you want people to come to a stop slowly. And so if you come to a stop very abruptly, it's more energy transferred to you over a shorter period of time, right? So that's a higher impulse, and that creates more energy and is more bone breaky. So typically we actually want people to, if someone's having a big fall, you want to allow them to slow down slowly. So like coming off the ground is helpful, with the big caveat being you don't want them to hit the ground, right? Or a ledge. So that you have to make sure that there's not so much rope out that they slow down so slowly that they hit the ground or that they hit some sort of obstacle or a ledge. So really active management of belaying is really helpful. But if someone's going to take a fall, particularly if they're not far above their last bolt. So if he was only 4 or 5 feet above his last bolt, that can be a very hard catch, right? That can be very, very jarring because there's not a lot of rope to stretch, because the stretching of the rope is a percentage of its length. So the more rope you have out, the more stretch you have, and the more like the softer the catch is. So if you don't have a lot of rope out and you're very close to your last bolt, you actually kind of need to jump up or give like extra slack so that the person doesn't come to such an abrupt stop. Does that kind of answer that question at all?
Yeah, that makes a lot more sense. Thank you for explaining that.
Yes, no problem.
I was also wondering, could you speak more about what your typical protocol and procedure is for cleaning and then wrapping the wound?
Yes. So for gross decontamination, I want to get any of the like dirt or sticks, leaves, that stuff out or off the wound. All you need to use is just any potable water. So water that you would use that's safe to drink is good enough for your for wound contamination. You don't need sterile saline. There's no need to use iodine or anything else in it that in fact will typically causes more cell death and things and impedes healing. So just potable water, manually removing sticks, dirt, things like that from it. And then you want to try to put if you've got any sort of a exposed bone, I think you want to put moist dressings over it to try to keep the bone moist, because if it dries out, that will devitalize the tissue, and just keep the tissue moist, and then splint it as best you can. Had we not gotten him out of there, I would have decontaminated as best I could, and we would have done some local anesthesia with lidocaine there, and then I would have tried to reduce the fracture to try to make sure that it was better controlled, the pain was better controlled, and that we maintained neurovascular status.
That's really cool. Thank you.
As an orthopedic surgery resident, I can echo exactly what you just said. That's what we do in the trauma bay in like a regular hospital for these injuries as well. We just use sterile saline because we have it.
Absolutely. It was, and then that's the thing. It's been sterile saline. Yeah, it's like totally fine and stuff. But like if you like the studies that have been done, like in the Austrian like environment, or even there's emergency department studies that showed like rates of infection with tap water versus saline that kind of didn't show any difference. So really the big takeaway is that if you are in a place where you don't have sterile saline, it is certainly bad to leave dirt in a wound. And so you really should wash it out, because bacteria like to grow exponentially. So over time you want to like cut down on the number of colonies of that crap in there so it doesn't grow exponentially bigger and bigger and bigger and have a raging infection that the poor orthopedic surgeons will have to deal with like someone in an X-Fix for like months while they have a osteomyelitis and open fracture and all that crap. Any common belayer injuries I see? Yes. The common belayer injuries typically relate to people either being pulled into the wall. So where that person you saw in there got pulled up off the ground, they sometimes can get pulled off their feet and pulled into the wall. The other thing that people will suffer, particularly if they're belaying with a tube style belay device like an ATC, like the kind of typical thing. If people lose control of their belay, they can get rope burns on their hands, are pretty common as well. The other thing too is people can get pinched in that device, like the rope runs through runs through the rope runs through a carabiner, and then through a tube device, and you can get your hand pinched in the rope where it interfaces with the device as well. Those, I'd say, the three most common bladder injuries.
I have a quick question. You mentioned the neurovascular damage and the contamination. Are there any other aspects that might go into your decision to reduce a fracture like that when you're in the field?
Yeah, so the other two things are, number one, if someone has neurovascular compromise, it's kind of a no-brainer. Like you've got to try to do something. The other thing too, that your big benefit to reducing a fracture is pain control, right? Like you can make, if people's bones are kind of near where they're supposed to be, they don't hurt nearly so bad. So that if you either had a patient or been unfortunate enough yourself to have broken bones, they generally feel a lot better once they're kind of back where they're supposed to be. So the other thing to consider is, if you're trying to, if you do need to attempt to reduce a fracture in the field, getting adequate analgesia to be able to do it with and have the patient tolerate it at all can sometimes be a thing. So if you're trying to improve their pain, it's sort of, if that's the only reason and it's so painful that they can't even let you do it, then I wouldn't attempt it in that case. Local anesthesia helps with certain fractures and stuff. We have ketamine in our kit. It would be really risky to do a full dissociated sedation somewhere like that without any monitoring or anything like that. You theoretically could sedate someone with ketamine to do a procedure like that, but it would be unnecessarily risky in most cases to do something like that, because there's other ways to control people's pain if that's the only concern.
Hey, Dr. Davis, could I ask a question?
Yeah.
Hey, my name's RJ. I'm an EM intern up in Pennsylvania. So like, I feel like for EM residents, it's not super common to do regional nerve blocks in the department, but I feel like that's like a newer, like it's becoming increasingly more common. Do you do that frequently in the field? Like you said, you brought out lidocaine. Have you ever done that?
I have not ever done no, I guess we have. We have done a regional anesthesia in the field with Wooten Jones, who's there on the top, and we published a case study.
Yes, we have, Chris.
Yeah, so I was like, yeah, we have. Why don't you tell that about that case? I should have included that one in this thing as well. That also happened in Limble Gorge.
Yeah, so that was also in Limble Gorge. We had a hiker who had kind of slipped on a route, I believe, put his hand out behind him to break his fall and ended up anteriorly dislocating his shoulder. We were about, I don't know, a mile and a half down, not a particularly arduous trail, but and he had gotten some fentanyl by the kind of hasty team that showed up, one of the special operations paramedics there. We showed up carrying an ultrasound and some local anesthetic. We were able to ultrasound, confirm that it was out, confirm no bank heart lesion, and then did some intra-articular lidocaine, and then just your standard countertraction, traction, reduction, and then a sling and swap. So the benefit to that is, could we have given him adequate analgesia to do that with fentanyl, through other means? Absolutely. But something that would have made that more challenging is now he's a carryout instead of someone who can walk out under their own power. So by doing that, we were able to get it reduced, and actually he walked out under his own power and would have actually driven himself to the hospital if his car was not a standard transmission, and so he couldn't drive and shift gears. And his girlfriend who was with him didn't know how to drive a stick. Yeah. But yeah, I think if I could offer I'm did EM and I am and now doing critical care. If I could offer one piece of advice to you as an EM intern, just starting out, learn regional anesthesia. I think it's going to be a major benefit to you in the future.
I'll take that to the bank. It's just interesting because it also, brings in the whole like the idea of pre-hospital ultrasound too, which is also becoming, increasingly more popular. So yeah, thanks for sharing.
Chris, you're muted.
Oh yeah, here you can see that Alex here is doing a in-plane injection into the glenoid fossa of lidocaine there using is that a Lumify, Wooten?
I believe it was. Shout out
Lumify.
to the nice folks at Philips for lending us an ultrasound to take into the woods.
Yeah, I have I use a Butterfly as my personal thing I use in my kit. But it was and you can I'll send a link. We published that case, and I'll put a link to that in the chat too. Anything else?
And I'll do my best to send these articles Chris is sending out in like next month's Journal Club email. So don't feel like you have to rush to download it, but if you have access to it, take advantage of it.
Did you? Oh, yeah, Wooten got it. I was looking for it right now. So excellent. So yeah, so that brings up a good if you want to kind of some details of that case, but you get to see the cool pictures anyway. We couldn't publish those pictures because Alex didn't have gloves on. The picture, so anyway, like a true EM resident, no gloves for the procedure.
No BSI, no scene safety.
Scene was not safe.
I don't know.
No BSI on.
Yeah, it's almost as though some aspects of remote backcountry rescue are inherently unsafe, and you do them anyway. I don't know. Someone maybe could rip off that.
Yeah. Anything else, y'all?
Any questions on suspension syndrome, the article, rescue scenarios, anything like that? We've got a couple minutes, but it's been an hour and 40, so we're nearing the end.
No, I mean, this was a fun topic. Thanks for picking it.
Yeah, thanks for your help, TJ and Chris. Next month, we're going to be covering cave rescue, which is
scary.
Probably a more difficult scenario and location as far as access, communication, cold stress, just the mechanics of the operation rescue itself. We're going to be joined by one of the Blacksburg EMS directors, who's also their cave rescue director and instructor, Eric Stanley. He'll be joining us, and one of our fellows is going to be running that Bree. And first off, I've got Brian. I have added you to the email list. And then Holly, yes, this recording, is that what you mean? This session's recording will be posted on the YouTube page in a couple of weeks. Is that what you're referring to, Holly? Yes. Okay. Well, thanks for joining, everybody. Like I said, these articles will be added to next month's email, and I'll see you next month. The next session scheduled for January through June will be posted shortly. I'm just nailing down a date for June. But I'll see you next month. Thanks everybody for joining. I'm going to end recording, and anybody that wanted to hang out and chat about other stuff, we can do that as well.